Welcome everyone. We're here for a guide to navigating New Jersey mental health system. I don't know that there's going to be any magic wand, but hopefully we'll give you a basic understanding of the mental health system and what programs are available, and maybe we'll have time for some discussion and some ideas on troubleshooting the system, which is really much more difficult. There are two handouts you should have gotten when you walked in. They're on the chair. One of those is the PowerPoint that we'll be using today. The other one is just a quick reference guide. And this one in particular I want to bring to your attention. It's a directory of mental health services. The whole directory is about 120 pages, so I didn't want to bring down that many trees, but you do have the URL, the address that you can get this and download it. The Division of Mental Health Services puts it out. They update it on a regular basis, and on the inside page you'll see the table of contents and all of the programs that you're able to get information on. Also, this guide, this program is by county, so you can either reference it by program element or by your county. I put in a page of all your local IFSS programs, Intensive Family Support Service programs, because there are always great sources for navigating the system. I think everyone should be aware of how to find the NAMI New Jersey website, naminj.org, and that'll take you to each of our county affiliates. Page with your designated screening centers. This is the emergency psychiatric service in your county. For better or worse, that's frequently an entree to the mental health system. And lastly, this is really an important one to take a look at too, and you should really spread this around as much as you can. Calling 911. And it's really a tip sheet that was put together by a police department in Newport News, Virginia, but it really pertains to all police departments. When you need to access the police, this is really a good primer on what you should be saying to the dispatcher. Yes?
This should be copied for all family-to-family classes and given out as a little handout to the family-to-family classes.
I agree with that. Yep.
Yeah,
I've included it now when I'm doing week 11. The ones I do, I include that, but you're 100% right on that. Okay, so why don't we start? So our learning objectives today are to provide an overview of New Jersey's mental health system and to help you find resource materials and contact information for public behavioral health services. Again, so we're going to be focusing today on the public, primarily adult mental health system. Okay, and then there'll be parts to familiarize you with generic entitlement programs that you can access that are meant to support people with a mental illness. Some things like rental assistance. We'll have a little bit about Social Security and some other generic services that I think will be helpful. There are handouts on the chair. Okay. So everyone should have those. So when we get going. So basically the Division of Mental Health and Addiction Services provides mental health services throughout the state through contracts with more than 120 community-based not-for-profit organizations, right? So the mental health, the Division of Mental Health doesn't necessarily provide any services itself, but what it does do is contract with a vast array of nonprofit organizations. So again, this is reiterating the URL for that directory. So this is a very rough sketch of sort of the organization of mental health services. Just trying to scale for size, I had to use a lot of initials here, something that if you find me doing as we speak, please yell at me or throw something, and I'll try to speak common English. But this roughly gives you a flow of how person with mental illness will access mental health services and where it will go from there. The two key things here are, the consumer is either going to go to a mental health center or through emergency services. Then there are going to be some offshoots of that. It's important that I have IFSS up there on the top, and the same goes for our local NAMI groups, okay? And then you sort of get sifted through this system, and I'll talk about a little bit about the various levels of the system. So, community mental health services, among these agencies in New Jersey, there's a wide variety of community mental health programs. Many of them provide a complete array of mental health services. Generally, those are known as CMHCs, or Community Mental Health Centers. But then there are also providers who may only provide one or two of the programs that we're going to be talking about. There's no difference in terms of quality. A program that might be offered by a mental health center as opposed to a program that may be done by a smaller nonprofit. It's just in size and organization. So why don't we start with inpatient services, right? We have an inpatient portion of our system. We have community portion of our system. Each one gets funded about the same amount. I think at least the state hospital system is about $300 million. The community system is going to be between $300 and $400 million. Overall, when we add Medicaid into it, New Jersey puts about $1 billion, with a B, billion dollars into community mental health services. So we have 4 psychiatric hospitals, Ancora in Camden County, Trenton in Mercer County, Greystone in Morris County. They serve populations regionally. Then we have Ann Klein, which is a forensic hospital that's on the grounds of Trenton Psychiatric Hospital. Along with those 4, there's now currently 4 county hospitals, psychiatric hospitals. They're vestiges of old public welfare institutions that probably existed from the 1800s. So the 4 remaining hospitals are Bergen Regional in Paramus, Essex Hospital Center, which is a newly built Essex Hospital Center. Why am I forgetting? Cedar Grove. Meadowview Hospital in Hudson County, and Runnels Hospital is a smaller county hospital that is in Union County. They can have lengths of stay generally from a week to 30 days. Runnels has a little extended stay. Runnels, you might be able to stay a little bit longer. And I guess in Bergen, you might stay longer. Bergen's a pretty big facility. Then along with that, there are at a minimum 4 private psychiatric hospitals in New Jersey that do involuntary commitment. So these are beds for people who've been involuntarily committed to psychiatric care. They're generally locked units. A little later on, I may have the criteria for that, but if I don't, people are interested in commitment criteria, I'll be glad to cover that. So Hampton Hospital in West Hampton, they do both mental health and substance abuse and dual diagnosis. Carrier Foundation in Belmead on the, I guess that's Somerset County on the Mercer border. They also do dual diagnosis. They'll do mental illness, substance abuse, dual diagnosis, mental illness, substance abuse, and geriatrics. Summit Oaks in Summit and Ramapo Ridge in Wyckoff. Okay, so those are private hospitals that have locked involuntary units. Along with that, we have a system in New Jersey where we have 25 short-term care facilities. Those are referred to as STCFs. They also have locked units. So for people who are in need of involuntary commitment, New Jersey typically has a policy that before anyone goes to a state hospital, they'll go to one of these STCFs. Much shorter length of stay. The length of stay is going to be between 3 to maybe 14 days. Okay, so you're hoping to stabilize someone very quickly because they're in local communities. A person's life becomes much less disrupted. It's much easier for families to visit those facilities. Then there are also psychiatric units. Primarily, these are voluntary units that will be in regular general hospitals. So I don't have a full listing of that, but you can think of some of the regular hospitals in your local communities. Many of them, or 21 of them, operate voluntary units for about 853 beds. Yes?
Quick question.
Sure.
Pardon my...
No, that's fine.
Can you explain just a little bit between involuntary versus voluntary? What is that difference exactly?
The major difference is a person's willingness to go into a hospital.
Okay, so but they have to do what they for this, they must say...
So for involuntary commitment in New Jersey to an inpatient unit, you have to be a danger to yourself or to others, or property. Part of the commitment standard has to do with how immediate that threat is. And part of judging dangerousness is one's ability to provide for food, shelter, or medical care without the assistance of others. Again, the immediacy of all those comes into play. And then it has to do with the person's willingness to go into a hospital and there is appropriate service available for them. There are two parts to that test. So generally, for involuntary commitment, you have to meet all those criteria. Then they can determine whether you're appropriate for an inpatient, being placed in the hospital, or outpatient commitment. Under that, a judge issues an order that confirms a treatment plan, maybe going to treatment, going to a program, may include taking medication, and you're ordered to do that but on an outpatient basis. Again, it depends on how close you are to meeting that dangerousness standard. I think you started to have a question?
Yeah, what's the difference between county psychiatric hospitals and private?
County hospitals are government hospitals, government-funded hospitals. Okay, so they're parts of county government, and again, they existed from way back in the 1800s. At one time, we had a few more of them. They're social welfare institutions, but without getting too complicated, again, one is run by county government, the other one would be by private enterprise. The county hospitals are funded about 90% of the cost of the hospital. County hospital is paid for by state government.
Okay.
So that pretty much covers the inpatient units. Okay, so before I go on, are there questions about the inpatient units? So one of the keys then to get into an inpatient unit, in New Jersey, almost everything is funneled through psychiatric emergency services. And every county has at least one of these. We can think of them as psych ERs, for lack of a better term. They go under different names in different counties. So some are referred to as PES, Psychiatric Emergency Service. Some of them referred to as SKIP, although I can't tell you what SKIP stands for. Maybe someone in the room can, but so they're known in a couple of different ways. But remember that second handout, I gave you a listing of those, and you can find them in the mental health directory. So New Jersey, since 1986, has set up these emergency rooms, and they try to funnel everyone who's going to need hospitalization through these kinds of emergency rooms. There they have certified psychiatric screeners, generally a master's level mental health clinician, either an master's in social work, master's in counseling. Then that person takes coursework that's authorized by the Division of Mental Health Addiction Services. They become certified as a screener. So that person then would interview the person who came to the psych ER. If they believe that person meets the criteria for commitment, then a psychiatrist would be available for a consult. So generally there has to be a doctor or psychiatrist signing off on it. In New Jersey, you can hold someone immediately for 72 hours, but I think a person can be hospitalized up to 20 days before you actually see a judge. I think they may have to have a judge's order, but before they physically go in front of a judge, there's usually a 20-day period. Many people are discharged prior to that 20-day period. That would also be one of the ways to get voluntarily admitted to a hospital as well. Again, the person goes, meets its standard, is willing to go in, then in many instances they would be voluntarily admitted. Okay, so this is the criteria we talked about. So this is just a brief diagram of acute care, the acute care services where someone is in, immediate distress. What I've added to this, however, are two services that we'll talk. So first we'll say, person goes to Psychiatric Emergency Services, then these are basically the outcomes, right? You will, the person's fine, they'll just refer them to outpatient services, or back to, if they have a mental health provider, you just get referred back to your mental health provider. Voluntary hospitalization, the person agrees. Involuntary outpatient commitment. Again, this is relatively new in our system. It's hard to say relatively new, 7 years in the making. Ideally, a person could be ordered into treatment with a treatment plan prior to getting to that point where they are imminently dangerous. Only about 1 or 2 counties in the state are implementing the law in that way. In most cases, people are being committed to involuntary outpatient commitment after they've been hospitalized. Okay. So you've been hospitalized, you have like a 3-day stay, it could be a week stay, but maybe you have a history of responding well in the hospital when you're being medicated. As soon as you get out of the hospital, you stop taking medication. So this is a way of assigning someone to involuntary outpatient commitment. That requires a case manager to follow you, to help you, in the way a case manager would, to connect to available services, but also to monitor your compliance with the court order. And if you are in material non-compliance, not that you missed, you overslept one day, missed the bus, and didn't go to your program, but if you are really, you've just quit the services, maybe quit medication, that case manager is required by the law to report back to the judge and the screening center, at which time you would be reevaluated to see if outpatient commitment continues to be appropriate for you or if inpatient commitment is now appropriate for you. And then involuntary inpatient commitment. So what's new in this slide are 2 things. Early intervention support services, EISS. It almost sounds like Old MacDonald, doesn't it? But this is a newer program that now exists in about 11 counties. And we're hopeful that it's going to go statewide because it's been pretty successful. So it's sort of like a pre-crisis. When a person's just starting to enter into crisis, they can go to this facility. And it's a little bit different in each county. So two examples. One in Monmouth County, you go, it's basically big office space, but they have therapists there. They have the ability, they have a psychiatrist. You could be prescribed medication. Also, there's places, where they have group therapy and things like that. So I think they have groups. But then in Camden County, they use something called a living room model, where they have all those services, counselors and things like that. But it's a big open room with couches and TVs, and you can basically just go there and chill. You can get mental health services, but you can chill. And sometimes that's what a person needs to bring them down out of a crisis. So it's really helpful if you can do that without going into an emergency room. So again, without becoming too technical, one of the problems about going into an emergency room is the minute you cross a threshold, there are a whole bunch of requirements that kick in that you might not think of as applying to psychiatric care. So you have to be physically cleared at that point. There's something called EMTALA, I think, which is a federal regulation. So that automatically means that you have to start having blood work. So think about this, you go in on a Saturday night and you have to have blood work. Well, how long could that take? Before they draw blood, they get it to a lab, it gets analyzed, gets back, so that's part of the reason some people are now staying 24, 48, 72 hours in a emergency room. There are other reasons, but that's really a big reason. So if we can keep people out of that and maybe determine who really is likely to get hospitalized on an inpatient basis. If you're hospitalized on an inpatient basis, yes, you need to be medically cleared, you need blood work. But if you're just going to get sent home, why do you have to really do all of that? So the more people that we can sort of screen outside of the emergency room, really the better. So the EISS services, and again, that's listed in the directory if you go to the URL, is one way. And then crisis respite. We just heard a little bit about crisis respite, didn't we? Or maybe not, maybe just my table. I have a brochure. 3 locations in New Jersey. We have 3 crisis respite houses, and they're really interesting places where they have some professional staff, but for the most part, it's peer providers, people with lived experience who staff these houses. So there's an immediate rapport with people. So people who are getting into, just getting into crisis need a respite to get away from where they were, or to have like a more inviting, supportive environment. They're excellent places. I think we have those listed in that directory of services as well. Yes?
Is that county restricted, those houses?
They aren't. They're regional.
They are
so
regional?
One is in Passaic. Now, it's in Passaic County. I'm not sure where.
Hailden.
What?
Hailden.
Okay. One is, I'm really familiar with the one that's in New Brunswick, right near, what's the name of the hospital?
Robert Johnson.
No, it's not. It's
St. Peter's?
St. Peter's, right down the street from St. Peter's. Nice, it's just a residential house, you wouldn't know. And the other one I don't know. It's, I would be wrong if I told you where it is, but it services the southern region.
Phil, can you go directly to outpatient services?
Yes.
So if my son is having some issues, I can just go to Princeton House?
Well, Princeton House isn't one of those contracted agencies. So Princeton House is more, Princeton House, I think of more as a private. So Princeton House, I know, again, for their inpatient unit, and then people can go from their inpatient unit to outpatient. But I guess if you had insurance, you could go to Princeton House's outpatient. Am I correct about that?
Yeah, I was just going to assist with that question. Princeton House works more like the University of Behavioral Health Care. It's a group therapy program. You're screened at the screening center, and then you will be transferred to either a counselor or a therapist to see if there's availability to accept the patient, and then they'll get back to you.
But I think
Yeah.
Princeton House has outpatient services, so, but that would, I think, mostly be for people who have insurance.
It's Monday through Friday from 9 to 3:30, and you have to commit to it. Yeah.
So the important, unfortunate thing to know, and this is, one of the problems with navigating, why, so it's easy to describe the system, it's hard to navigate the system. So you're going to find long waiting lists for all of the public mental health services. So in Mercer County, there are, I think, 3 publicly funded mental health centers. What had been Greater Trenton, which is now merged, Community Guidance Center, and let's see, what is the other? There's one right in West Windsor. But most of them are going to have 3, 6, 10-week waits before you're going to get an appointment. So are they great for someone who is in like an acute state? Probably not. You really have to be planful and apply to it beforehand. And you're going to find that, especially when we start talking about housing. I'm guessing there'll be lots of questions about housing, but housing you really have to plan for sometimes 2 years in advance. So is that helpful?
Yeah.
So our IOC, Involuntary Outpatient Commitment. Okay, so you have the slide, so you really shouldn't have to take many notes. And just like we said, it's court-ordered, assistance with linkage community-based services. The case manager basically just monitors. Ongoing assessment of the clinical progress, can just keep track. And then interface with the judiciary, because not only are you going to report back to the court in material non-compliance, but remember, you are involuntarily committed. This is a civil legal action. So because of that, that commitment has to be monitored by the courts. So on a regular basis, you have to go before a judge who is going to determine where you are. So you either need to continue the commitment, or in many cases, the person's complied, is doing well, and the commitment will end. So then, talk about just general division of mental health and addiction service funded programs. And so we talked a little bit about some of the outpatient services. We'll talk about some more. Then there's partial hospitalization and partial care. Somewhat similar, different. Partial hospitalization usually is following a hospitalization, and it really acts as a step down from an inpatient stay, whether that was an involuntary hospitalization or a voluntary hospitalization. It's just a more intensive daily program. My understanding is partial hospitalization now is a time-limited program. But then there's something called partial care that can take place in a hospital, but frequently it's more in a community mental health center, or it may be a freestanding partial care. I know of one in Flemington. It's just a commercial space that is rented by an organization. There they have mental health counselors, right? And so you would have individual treatment, maybe, certainly group treatment, but then group socialization programs. Generally, they will have a psychiatrist on staff as well. And, that can go on for quite some time, and people can be in those programs for varying amounts of days, anywhere from 1 day a week to 5 days a week. Some of them have some other programs we'll talk about, like supported employment attached to that. But most of them are going to have what are called pre-vocational programs. They're trying to prepare people to go back to work as well. Yes?
This definition is a perfect explanation of the previous diagram for outpatient services.
Yeah.
This is what they would, how they would work with.
This would be
your
one
family
of
and
the
patient.
one of the places
Yeah,
you'd
for
end up
outpatient
going.
services like Princeton University Behavioral Health Care, Princeton House. And it's a commitment. It has to be.
So that would
available.
be one alternative, right? Another
Yeah.
alternative could be an individual therapy, You could just go to have medication monitoring. There are a couple of different ways that you could get funneled from that outpatient center. So integrated case management, this is having a mental health case manager. What's a little bit different about this is that you don't have to necessarily go to the mental health center to see this person, although you can. But this program, the mental health worker can come to you. Okay, so it's varying intensity. Generally, I think everyone who has been to a state or county hospital is eligible for this. And then in varying degrees, people who've been to probably more than one inpatient hospitalization in one of those STCF, short-term care facilities, they might be eligible for this too. I think it's generally an 18-month to 2-year period, although we're told you can ask that it be extended. So again, basically in this one you're going to see a case manager, this mental health professional, maybe in the beginning on a weekly basis. That might schedule might lessen over the course of time. Now, a more intense program that's somewhat similar is something called PACT, Program in Assertive Community Treatment. As it was originally intended, PACT was for people who, for whatever reason, they were resistant or just problems in the system itself, requirements that you had to keep regular appointments. They really did not successfully engage in the community mental health services system. So these are programs where you have smaller caseloads, usually about 15 people to a caseload, and instead of having a single case manager, you have a team. And as designed, although not always as implemented, that team would include a psychiatrist or an advanced practice nurse. And again, in many instances, as designed, that prescribing person would come right out and find the person, whether it's in their house or a place where they hang out. It really is, their assertive was supposed to be it. They were supposed to not just wait for the person to come to them. They were supposed to assertively go out to the person. Then it would have a social worker or a licensed counselor. As designed, it would have a substance abuse counselor. It also would have a rehabilitation counselor who was supposed to help someone find employment, right? So again, you had a team of 4, 5, or 6 professionals who would be responsible for 15 people. Right? So you can see that is pretty intensive.
So how would you enroll into this program?
I'm sorry?
How would one enroll into this program?
You don't enroll into it, right? That's one of the problems with...
Is it through the county, like Middlesex County multi-assistance
Generally,
program?
you're going to get into this program by having been at a state hospital or be a person who becomes really well known to your county mental health system. So we have these county hospitals. Again, you've been a person who's repetitively gone into those hospitals. For some, there may be limited places depending on how full these programs are in given counties. You may have the ability to sort of petition to get in without having been in a state hospital. Jay, you had a brief...
Well, a couple of quick thoughts. So Phil definitely used the concept of as designed, and yes, Jersey has deviated a little. Although we do have a technical and training assistance center that helps PAC teams. We have 31 teams in the state, and it helps them stay.
Jay, do you want to address that admission criteria part, though? I think that's the
Oh,
question.
that specific answer is that I know some teams, so some teams will take community referrals up to now. Now, that'll change after June 30th, but up to now, it has been under the control of the Division of Mental Health analyst, either the one responsible for the county or to the analyst responsible for the PAC program. Who is that now, do you know, Bill?
John Vernon.
It's still John Vernon? Okay.
Okay, so why don't we say this?
They've been able to do it.
So then in all the programs we're talking about, they're going to have what becomes a problem for navigating the system, they're going to have different eligibility criteria. There are also going to be some exceptions. And then there are going to be different kinds of exceptions. In many instances, the way to gain entry to a program, if you don't meet the strict criteria, and you're only going to do that if there are vacancies in the program, because most of these programs, because they're state funded, are meant to reduce or to keep the population of state hospitals down, because that is the greatest cost driver to the state, is through either a mental health administrator who, and I'll give you a little talk on them in a minute, who is a county level employee who oversees the mental health system in that particular county, or through what is called a program analyst. That is an employee of the Division of Mental Health and Addiction Services. And every county has one of these people who acts as the liaison from the Division of Mental Health and Addiction Services to that county. Sometimes they can at least go through the chain of command to get an exception. Yes?
Did I hear that the county mental health administrator could refer to a PACT program?
The county mental health administrator does have some ability to intervene. Whether it's going to be successful or not is another situation. But keep in mind, a lot of the programs we have, although they're state-funded programs, we still have a really strong county system in New Jersey. And particularly if you're going to try to cross counties, you're almost always going to need the permission of the county mental health administrator. Whether that's a politically correct protocol or not, that you almost always have to involve that person.
Your county,
What?
your home county administrator.
The county, for the county that will be accepting the person. Because they will always make the case that, we don't have enough mental health services in our county to meet our own population. Why should we be then giving it to someone from out of county?
Because if you're successful, we don't want to move into your county. They will just love it.
But for most of the time, our folks don't buy the expensive.
The most common way that happens is consumer is living in one county, the family is living in another county, and they want to bring their family member closer to them. So supported employment is another division-funded program. So this is a program that's meant to assist a person into becoming employed. And every county, I believe, has at least one supported employment program. Anybody is eligible for supported employment. In many places, and again, if you go to that directory, you'll see who runs the supported employment program in your county. Most, again, are run by community mental health centers, maybe in conjunction with what we call the partial care program. However, you do not have to be a client of a partial care program to be involved in supported employment. So I'm just going to make one quick comment on this, and then we'll move on. Supported employment is really a program that lots of people want. In 2001, I did a housing survey for NAMI. So it was really, the survey was about housing and housing needs of people. Over 1,400 people applied. But as part of that survey, then we asked people what services that they need that weren't available. And the number one service was supported employment. So I can tell you that since 2001, the number of supported employment slots has not increased at all. So it's, for whatever reason, it's a program that's really valuable, people want it, but it's dead in the water. We're gonna get one.
Dead in the water, meaning what?
Meaning,
Nobody's using it, or?
no, it gets used, but
But
they,
not enough?
the number of available positions in it hasn't increased.
And shrunken a little.
It's diminished.
The staffing?
Well, that's partly, it's diminished because Department of Labor was putting some money into it, and that money is.
Just dry up, okay.
Okay, so DMHAS, Division of Mental Health and Addiction Services, provides a wide range of services to provide supports for families of people with mental illness, and for the homeless, mentally ill, and for people who abuse drugs and alcohol. So we're going to go through some of those as well.
Is supportive education DMHS?
Yes, it is. So supporting education is sort of an interesting program. Jay, you might want to comment on that
So-
one, but I don't know that supported education doesn't really run as if, some of the really outstanding programs that exist, like in Massachusetts or something like that.
Well, interestingly, we could have a whole day on it, not bring the talk out to your local NAMI group. But what happened is that there is best practices. Supported employment is a research-based, evidence-based practice, like PACT. You can research and say, you have to do this, you have to do that, you have to
Jay,
do this.
supported
Simple, right.
education.
Supported education is not quite there yet for reasons that are outside the scope of this discussion. We do have programs, mobile supported ed programs that'll work with people who are pursuing any post-high school education. Brittany Stone is in one of the other rooms here, and Brittany works in a program out of Rutgers Department of Psych Rehab that disseminates that practice to, there's about 5 or 6 agencies covering about 13 counties that offer mobile supported ed. So Phil's work on a calendar, I'll chat offline more about supported ed.
Okay, so if someone wanted supported education, where would they go?
If they, in the division directory, it lists the count per county. So, name a county, and again.
Well, people have the directory,
Fine,
URL.
so I'm just saying that that service is often not in the county because they're multi-county catchments.
Okay,
So-
so we have, the directory also lists by program element. So-
Right, and supported ed is one of the elements.
So let's go to our table of contents, right?
Is Department of Education Services?
No,
Okay.
there's a lot of
So-
people who can.
So there is a listing for supported education.
Okay, thank you.
So residential services, this is a morass. So residential services, there are a variety of residential services that are funded by the Division of Mental Health Service. So the programs for adults with mental illness in the community, generally those residences traditionally, although there's been some change in about the last year or so, are either owned or leased by mental health agencies. They provide support, encouragement, development of skills. They're basically there to help people acquire those skills that would be required for them to live in the community. And this is funny, this is the division's own word. The consumers live in the most normalized, least restricted environment possible, promote individual growth and safety. So these are, it's really hard to describe this because there are a lot of different sizes. So it could be in a residential setting where there could be 10 people living in a place. And it could have mental health staff on site, either bachelor's level with master's supervision. Could be up to 24 hours a day, 7 days a week, right? They're doing lots of supervision, lots of training, monitoring people's medication. Some of the newer residences are going to have some nursing services attached to it. So we could go from that, although most of the residences if anything like that is being developed now, and very few are, except for specialized populations, people who have physical illnesses that require medical attention on a regular basis, or people who have had involvement with the criminal justice system. Those are the residences that are being developed now that would have, that degree of supervision. But it can have the legacy housing, the ones that already exist, generally are going to have either 24-hour supervision, very few of those left, difficult to get into those. Maybe some have 12 hours of supervision, so that 12 to 24 hours usually referred to as Class A-level housing. Then there's B-level housing. Generally, those are going to be like apartments, or condominiums that agencies are leasing around. We can have about 4 to 12 hours of supervision a week in those. Those are level B. I think that might be the majority of those. I think between level B and level A, there are about 1,500 beds in the system. Not a lot, because Jay is saying that the number of actual people who are served by the mental health system is really under debate. It's going to be between 150,000 people a year and 250,000 people a year, depending on whether or not you include people who access emergency services. So even taking the low number, 150,000, if there are only 1,500 beds, what's your chances there? Someone can do the math faster than me.
That would be 1%, just to do the magnitude.
Not great.
2 decimal orders of magnitude.
So then there's level C, and that's basically 4 hours, 1 to 4 hours a week. Those are generally people that are moving out of these residential programs and getting to live on their own.
So,
Yes.
the 99% of those folks that don't get those, what happens to them?
We know the most common place is people live at home.
Okay.
And presumably after July 1st, people will be able to buy community support services, even if they're not living in a residence with services. And that should make that more effective.
What's
So-
gonna happen in July 1st?
Yeah, what?
Well, why don't you pick that up, Phil? CSS will be for anybody who applies and says they need it.
Why don't we wait, and we'll see, maybe we'll have a slide there. Maybe we won't.
Okay.
What's the most common eligibility criteria for residential services in general?
So the ones we just talked about, 85 to 90% of those people have gained access to those residences by having been in a state hospital. So again, most of the services in New Jersey that are funded by the state are directed towards people who have been in state hospitals. The next level is going to be people who come from county hospitals. And then the next level is going to be people who are coming from community hospitals. And then a number, I'd say a small percent, 5 to 10% at the most, would be people who are living in the community and have experienced psychiatric problems on an ongoing basis, or who are mentally ill and are at imminent risk of being homeless or have been homeless.
So hospitals couldn't keep them for a longer period of time, and essentially they're being moved into these facilities.
I'm sorry, the first part of that?
So hospitals couldn't keep them for a longer period of time and in and out and so forth. So finally, somebody took a decision to move them into residential facilities.
To some extent. The state hospitals are keeping people a much shorter period of time now, but yes, they do keep people up to 6 months past the time when they could conceivably be discharged, just because there's no residential setting appropriate for them.
A local
And always keep in
hospital?
mind, hospital beds cost us $1,000 a day.
A local hospital or a state?
Any
hospital?
hospital, local hospital more than a grand.
Yeah, but what some people don't understand is that the hospital bed costs $1,000 a day, whether it's occupied or unoccupied.
Right, so the case is, why occupy an expensive resource when you can get out and get an $150 a day bed?
I just wanted to say that my experience in Sussex County is that there's a mandate that the supportive, the residential services programs have to serve people being discharged from state hospitals first. So the only way a community referral gets in there is if there's openings.
So, that depends on two things. So one, it depends on the total number of beds, the availability of beds in a given county. So another survey I did, and it's changed a little bit, but the two counties that had the lowest per capita number of supervised beds were Sussex County and Salem County. So particularly in those counties, there's not a lot of play in the number of beds. Other counties, it may be a bit different. The other thing that comes into play, and that is, let's see, what was the other part? So you said that Sussex County, oh yes. So really, the mandate exists in contracts, and this may be something that changes because we may no longer have contracts with agencies, but we're not really here today to talk about the switch to fee-for-service. That is maybe a whole other workshop. But as things stand now, a residential service contracts with the state of New Jersey to provide certain amount of service. So for example, what you might say is that during the course of the year, I'm going to take 20 people from a state hospital. So again, you're taking that 20 people from the state hospital. You might say that I am then going to take 5 people from a county hospital or a short-term care facility. That's your contract, so that's where the mandate exists. But if you take those 20 people, you know, it doesn't say you have to have 20 people at all times who were in a state hospital. So if I took those 20 people and 16 of them leave the program for whatever reason, I do have room to put someone who meets other than that criteria. So the mandate actually exists in the contract that the state signs with every particular agency. And there's some room within that contract to do things. Certain counties, when I was in Hunterdon County added on to the state contract. So Hunterdon County would buy 5 additional beds, right? So that would allow for people who didn't come directly from a state hospital. And if you're on the county mental health board, you know, that might be something that you want to have a discussion about. You know, why isn't that we're doing this? Just in the same way that some counties add on to emergency services so you can have more mobile outreach. Remember, we talked about trying to prevent people from crossing the emergency room threshold. Well, one way to do that is by having a lot of these screeners who can go out to people. So some counties literally put extra money so that there's more availability. Some counties, the hospital puts money into that emergency service contract just because they don't want people with mental illness clogging up their emergency room. But for whatever reason, that's a win-win. So then, more of what's happening is called supportive housing. And supportive housing is designed to ensure consumers of mental health services a choice in permanent, safe, affordable housing. You know, the key feature of this is that the consumer, the person with the mental illness, in many cases holds the lease, right? And this really started because, you know, lots of these housing programs were really quite coercive. You know, if you don't do this, you're out of here. And because it's a monopoly, and we know only 1 in 100 people can get the housing, you know, it had the potential to be really coercive. But, you know, the belief is that many people now, you know, in a variety of circumstances, do best if their housing is first stabilized. So this was really meant to address that. So a key feature again is that the actual person with mental illness holds their own lease. And again, in theory, the mental health provider is to offer a service that the consumer finds to be valuable enough that they are going to invite the person into their house. Yes,
So is transitional housing right before this?
okay, yes,
Oh,
yeah, that's a good point.
What's the availability though of these?
So we said
You know,
about,
and they hold
we
the
said
lease,
about
but-
50, there, I think about 7,900 of these. So the important thing.
Better.
It's actually a lot better. And New Jersey's made a real effort to expand this kind of housing. So there have been 200 to 250 to 500 units built on a yearly basis with supportive housing. And it looks like there's going to be an effort to do even more.
And the state is the landlord? Or-
No. There are a variety, almost all cases, private groups are the landlord. So you can develop housing in a number of ways. A lot of the housing was developed through federal grants, HUD grants,
Right.
grants from the
Like Section
Department of Housing and Urban Development. Another way of doing that is through Section 8, and I think I have a little slide on that. So
Okay.
that's rental assistance, right? There
Okay.
are a lot of varieties. We'll wait to the slide for that.
So how would-
Or, so HUD grants can then do that.
So how would you apply? Who do you apply?
Let's wait till
for?
that's, we'll wait till
Okay.
that's fine.
I'm sorry.
So the patient pays for the lease, so obviously they lease their own.
Pays for it, but it's almost in all cases subsidized.
Okay.
So another way would be, there's a state rental assistance program as well that's somewhat
Okay.
similar to the federal rental assistance program. And, fortunately, people with mental illness have had pretty good access to that. We're
Okay.
almost on the top of the list for the state rental assistance.
So you have to apply through the state for that assistance?
You have to apply in a variety of ways. Okay, we'll get to that.
Okay, I'm
Okay.
sorry.
Again, I think I said,
Once you
what
start-
did I say? I
started-
said, we're entering housing, this is where we enter into the morass.
Right, and I'll just keep asking questions.
Yes.
What is the private home where someone takes in, say, 4 clients and the clients are paying with their social security money, does this fit in?
It doesn't. It doesn't. So there are actually 2 varieties of this. There's one that is really an old system, almost like foster care, where there are something called family care, and they're a family or someone takes 1 or 2 people with mental illness into their home. I don't even know that there are many of these that exist anymore. I know there used to be quite a few in Essex County I visited. But then there's something called rooming houses and boarding homes, and those are really under the Department of Community Affairs. And typically those will be like a rooming house or a boarding house, or an old hotel was taken over, and there's an operator who provides meals and maybe laundry. And in some of those, the boarding homes, there might be a minimum of nursing care, a bare minimum of nursing care that occurs during the week. But those, again, are licensed and regulated by the Department of Community Affairs. My one little thing about that, the Public Advocate did a survey of those, and they found that about 50% of those were places that you would ever want to have a family member. So, if you're faced with that, you really want to do a good search and, go and visit and ask people, get a lot of information about it. Some are great, but there's many, many substandard facilities. Yes?
How do we expect people with mental illness to navigate through all this maze of, it's difficult for us.
Does anybody want to answer that question?
There's actually.
Does anyone who, Does anyone who hasn't had an opportunity to speak want to answer that question?
Well,
Yes. Rosemary.
Mark, I see to Margaret. Margaret?
Yes.
I can say, coming from the state institution, my son came out with a social worker and came out with plans to go into the community. And he still has those, I think he's one of the few that still has those services where people come to the home, they monitor his meds, and he's doing quite well with that service. There's not enough of those services, but he's still, and it's dwindling down, I notice a lot, as far as workers are concerned. But that's how he navigated the system. And Phil, when they come out of an institution, aren't they to have, what's that transition?
ICMS, we put the slide up earlier.
Yeah, they're to have that. And those folk are the ones that monitor, from my understanding, monitor their transition into the community.
But do we know that all this is now going to change once Donald Trump comes in? Because it's going
Let's order dinner.
Let me say this. Maybe Jay will have some thoughts after the conference, after we get done. You can speak to him in the hallway, but it's really impossible at this point to have a lot of conjecture. I think what's less unclear is the very immediate, because we're going to a new funding system for these services. And it's really difficult to even tell what that is going to be like. So, very quickly in one sentence or two sentences, I can give you, that. On the downside, the reimbursement that some providers may be receiving may not be adequate to maintain their services. On the plus side, there may be a potential now to really just access services without some of the restrictions that have been placed on these services. Again, contracts will no longer be the driving force, so if the reimbursement is adequate, it could lead to the expansion of services. So, but that we don't know. So before we even get to Donald Trump, we have to navigate what's happening in the New Jersey system beginning January 1 and July 1. So I see our time, 3:30 it's supposed to be?
Yeah.
Okay, so let me start going through some of these. Crisis respite housing, we talked a little bit about it already, right? We talked about EISS. Homeless services, so every county has a service to help people who are homeless and mentally ill. That's in your directory. At a minimum, we'll supply case management. In many cases, they'll help you find housing. That may be temporary housing, but at least you'll be off the street.
Those are paths?
Kath?
Yep.
Oh, is that what they're called?
Homeless services, I think it's in the directory.
Oh, it just said it on the thing.
Yeah, PATH. But I think in your directory it's called homeless services. Justice involved services, 11 counties have services to help people who are involved in the criminal justice system. They vary. Some help people right when they're getting involved. Some help them as they're going to jail. Some help them after they get out of jail. We need a lot more of this. Self-help, every county has at least one self-help wellness center, right? Where it's consumer-run centers where people can go, and there are a lot of activities, some just socialization, but some really therapeutic. I would suggest that everyone should know where those centers are. Intensive family support services, we know we have programs in every county. Especially if you need help navigating your system, you will have a professional a mental health professional who works for you as the family caregiver to help you navigate the system. Okay, they should be working in every county in conjunction with your local NAMI group. So then we have addiction treatment, is the other side of Division of Mental Health and Addictions. So there's substance abuse and addiction treatment services in every county. They use what's called ASAM American Society of Addiction Medicine placement criteria. So if you're looking for a substance abuse program, there's a directory on the Division of Mental Health and Addiction Services website. Right, so some of these are outpatient counseling, see a counselor once a week. Some of them are intensive outpatient programs, you go daily for a given period of time. Inpatient services are really difficult to find in New Jersey, primarily because there's a restriction on using Medicaid funding for inpatient programs. It's a long explanation, but believe me, it's the case. However, the Division of Mental Health, I understand, is going to announce momentarily that they're putting $2 million in additional money into inpatient drug treatment. This is done pretty well with the new funding system, and lots of new people who weren't eligible for Medicaid before, are now Medicaid eligible and are able to access addiction treatment services. So if you're also looking for services, just like we have county mental health directors, we have county alcohol and drug directors. This is the URL where you can access them. They're a great resource for directing you through the whole system. They'll also help, they really know about how to get someone in inpatient treatment if you need it. Sometimes it means going out of state, but these are pretty savvy people when it comes to that system. For children, everything pretty much goes through Performed Care. It's a managed care company for children. Also in the children's system, there are family support organizations. These are support organizations that were set up by the Children's System of Care in every county. They generally have paid staff. The paid staff are generally family members as well. And they help with a lot of
Under the age
services.
of 18 for this, or the age of 21?
18, if you've entered the system by 18, you can be in the system for most services up to age 21. So quickly, some generic services. Social Security, so there's SSDI, basically a service for people who have some work history. It's essentially an insurance program. Usually, if you get that, that will come with Medicare. There's a 2-year waiting list, or 2-year wait from the time you become eligible for SSDI until you are eligible for Medicare. You get Medicare. Social Security disability doesn't mean you're disabled forever. It means that you won't be working probably for the next year. So some people say, you know, do I really want to have my family member give up on working forever? You know, it's not forever. So SSI is, again, Social Security benefit. Again, a person meets that disability criteria. However, they haven't paid into the system. It's essentially a welfare program. But you do get a regular monthly income, not great, and you get Medicaid. Okay. A couple of things to keep in mind. It can take a long time, but it makes sense to apply as soon as possible, because even if it takes a long time to get it, you are eligible for payment going back to your application date. Right? So you could end up getting a big check. It's worth it. Second thing, it's not unusual for people to get denied 1 or 2 times. If you've gotten denied twice, there are plenty of excellent public interest law groups that will not charge you, your family member, a dime for appealing. And what many people don't know, they are better than the high-priced lawyers, because this is all they do. And they really are not in it to make money, they're just in it to do good. Yes.
It's called the Community Health Law Project.
That's one of them. Community Health Law Project, or Legal Services in New Jersey is excellent as well. Yes.
Which one you can get Medicaid?
So some people, okay, so we said if you've paid enough into the system. So some people have worked, but they haven't worked a lot. So they're eligible for some SSDI. But I'm trying to think what the cutoff is. If I'm thinking $600 a month, let's use that as an example. So the cutoff for SSI is like $600 a month. So say you've worked, but you've only worked enough to get $500 a month. So you're not only going to get your $500 here, but you're going to get $100 here, right, to bring you up to the minimum, $600. That's called a dually eligible. In that instance, you're eligible for both Medicare and Medicaid. Okay?
Thank you.
Social Security has a great website right there. It's really easy to apply through there. The application process isn't easy because you have to count on your mental health professional to send in the documentation, but it's really one of the better websites you're going to come across, and it's going to explain disability and everything you have to do. Okay. So this gives some of those criteria.
So I guess, for kids 18 or 21, I guess, only thing applicable is SSI, right?
In most instances, because a person wouldn't have a,
Right.
but what you're going to make the application, and they're going to tell you which one you're eligible for. You don't have to determine which one you're eligible for. They'll determine it for you. Okay? You'll just fill out the application, give them, the facts, just the facts, and they'll tell you what you're eligible for. So Medicaid is actually known as New Jersey Family Care. So you'll get that with Social Security, but it's important to know, as long as we have expanded Medicaid, that not only are you eligible for Medicaid now because you're disabled, you're eligible for Medicaid now because you have a low income. That's really important for a lot of people with mental illness. So for people whose monthly income is less than $13.67 a month, you're eligible for Medicaid. Not because you're disabled, because you're poor. So this is particularly helpful for those people who say, I'm not applying for Social Security disability, I'm not disabled, I don't have a mental illness. Well, now the person doesn't have to admit they have a mental illness, they just have to admit that they're poor and they can get health insurance. So these are all the things that, for the time being, are covered. Let me tell you a couple of them. Dental care, which is hard to get. Prescription drugs, those are voluntary services under Medicaid. If there's a dramatic change in Medicaid at the federal level, we could lose those benefits. Could you imagine having Medicaid and not paying for medication? That happened in Oregon about 3 years ago.
I'm sorry, what would have to happen?
Some of these are benefits that are covered by Medicaid, but not all of them are mandatory benefits.
Meaning not every state covers them, and under the changes that could happen in the laws of this country over the next 6 months, it probably take effect in 18 to 24 months. Different things could disappear.
So let's just finish up real quickly. So here's how you apply. You can apply online. Okay, and there's a telephone number for you. So if you are in that 2-year period or you haven't become eligible, you can apply for pharmaceutical assistance for the aged and disabled. So New Jersey resident, you do have to be eligible for disability benefit, but you have an annual income under $26,500, you're eligible for PAAD. Generally, you're going to get Medicaid, medication with what, a $5 copay, I think, something like that? So know that. Again, this is all in your handout. So this, if you're not eligible for any of these programs, many of the pharmaceutical companies join together. They have this partnership for prescription assistance. You're either going to get low cost or free medication. It's sort of an ordeal to go through. You have to have your prescriber write to them. It's only good for one prescription generally, so each time you need a prescription, you have to go through it again. But you're going to get low cost or free medication. And as opposed to some programs like, say, for instance, Medicaid that has a formulary, this doesn't have a formulary, right? So you can get high-priced drugs by going directly to the pharmaceutical company that makes that drug. So, it's something to keep in mind. You're not eligible for it if you have any insurance coverage, drug coverage. But it's a great resource. So, I hate that we're out of time. I guess we should do another one just on housing. But these are some resources for housing. So Section 8, Section 8 is a certificate, a voucher that you get. Essentially, you pay 30% of your rent, and the voucher pays the remainder of the rent. My rent's $100. Say my income is $90. I pay about 30% of my income, $30. The voucher pays the difference between my $30 and the $100. If you don't have any income, basically you don't pay anything for the voucher, and it takes it all, pays it all. There are a variety of entities that have these vouchers. We try to send out as soon as we find that a list is open, because you almost always have to sign up for a list, but for the most part, many of these lists are frequently closed. But the state has a list, right? The Department of Community Affairs. Most counties have a list, and then many municipalities have a housing authority. They have a list. These resources are going to tell you where they are, right? So you can start calling around to get your name on a list, and you really have to be thinking 2 years at a minimum down the line. Sometimes they become available, you jump on them, but for most cases, you're going to have a long wait. HUD subsidized apartments. This is a list of all the apartments that Housing and Urban Development has subsidized. So you don't really need a voucher for that. The voucher is already part of the apartment. So if you get one of those apartments, you'll be paying just 30% of your rent. New Jersey Housing Resource Center is a good place as well. For the supportive housing, from time to time, the Division of Mental Health issues grants. As soon as we find out who are awarded those grants, if you're part of our advocacy e-news, we send you that list so you can call them right away. But you might also look in their directory that has supportive housing providers, and if there are ones in your neighborhood or in areas you think would be viable for you, give them a call and see if there's opening, because they may have someone who's left their program, for any given reason. So they possibly could have openings, so you don't want to leave any stones unturned. Food stamps, again, income-based. You're going to get essentially vouchers that will help supplement the amount of money you have for buying food. This is sort of self-explanatory. So these are just some additional sources of information and referral. Of course, NAMI, Mental Health Association. Mental Health Cares is sort of a hotline with questions, and they have a pretty good database of all the services that exist in the state. And of course, the Division of Mental Health Services with this number. Again, usually your mental health administrator is going to have a handle on a minimum of mental health services. But some things, there may be individual services in individual counties that are specific to those counties that we don't really know about. Some counties have special medication programs. Some counties have special legal programs. But you really have to find out from your mental health administrator. So that brings us to the end. And I'm sorry you got a little rushed at the end, but a question.
Can you post these documents on the NAMI New Jersey website and make them downloadable?
We can post the PowerPoint for sure.
Okay, great.
But if you go on the NAMI New Jersey website, there's a button on the upper right called Resources. And it's going to have a drop down. It's actually going to have more resources than I have in the document.